Welcome. What were the medical firsts in the steel city of Sheffield over the last 200 years? We set out to find these in the Overend-Knight series of medical history podcasts, named after two of the founding figures of medical education in Sheffield in the 1800s. As the University of Sheffield Medical School approaches its bicentenary in 2028, each episode in the series will feature medical discoveries discussed by scientists, medical experts and medical historians. Listen to find out about the personalities involved, life in Sheffield over the past 2 centuries, scientific research discoveries, and where some of the medical treatments we take for granted today actually came from.
You're listening to the Overend-Knight Podcast. This series is named after the surgeon Hall Overend and the physician Sir Arnold Knight, who were the leaders of the 2 rival medical schools in Sheffield in the early 1800s. The aim of the podcast is to celebrate medical discoveries in Sheffield. I'm Allan Pacey, academic and science communicator. And with me around the table today are Kate McAllister and Chris Millard, 2 historians from the University of Sheffield, Helen Crimlisk, consultant psychiatrist at Sheffield Health and Social Care NHS Foundation Trust. And we're also joined later by Josie Soutar, Managing Director for Sheffield Flourish, a local mental health charity. In this episode, we're going to look at the history of mental health care in Sheffield, and in particular about the stigma surrounding mental illness. Kate, you recently completed a PhD in the history of modern British medicine and psychiatry. Do you want to tell us a little more about today's episode?
Of course, Allan. So, over the last century, mental health care in Britain has undergone transformational change. Whilst people certified as insane, and I'm using inverted commas there, were once cared for in the asylum, today the treatment of mental illness predominantly occurs in the community. But through the efforts of local physicians, psychiatrists and service users, the movement of mental health care in Sheffield out of the asylum and into the community was linked to efforts to reduce the stigma associated with mental illness. And we're going to be talking a lot about that today in the episode. We still have a lot to learn about mental health care in Sheffield in the past, so we can understand how the changes in stigma and in healthcare provision were felt and experienced by patients. But by starting to tell this story, hopefully in this episode, we're going to offer a framework for such future research. And we're also going to show why history remains vital in helping us to engage with kind of these ongoing public and policy debates in the present.
Now, from my uneducated space in this, when I think about mental health care in years gone by and I think about literature and film, I kind of think about the asylum. Chris, you're senior lecturer in the history of medicine and medical humanities at the University of Sheffield. What was it like? Was the asylum an important thing in our history?
Absolutely. I think the asylum is perhaps a symbol of what 19th century healthcare was like. Now, it has perhaps been overemphasized in the historiography, in the written history, for, I guess, a couple of reasons. One is that asylums left huge numbers of records, and historians love to dig into these records, and they've got so much information. And the second reason is that from, I guess, the 1960s onwards, we have a lot of very famous critiques of the asylum system. The 2 most famous are by the French philosopher Michel Foucault and the anthropologist Erving Goffman, who had lots of really interesting things to say about how incarcerating the asylum was and how separate it was and how unjust all of this confinement was. And so that's why the asylum sort of dominates the history. But there is so much outside of the asylum, so much sort of both coming out of the asylum but also separate from it, like completely independent of it, that also characterizes mental health care. And we're starting in the history of psychiatry to sort of move away from the asylum a little bit and to start thinking about, well, what does the community mean? Do we have healthcare in the community in the 19th century? And things like that.
Kate, what was the situation in Sheffield locally in South Yorkshire?
So as Chris has kind of flagged already, there would have been a kind of range of locations for care in Sheffield during this period. So places like the home, local sanatoriums and separate wards within local workhouses. But there was an asylum in Sheffield. So the South Yorkshire Asylum, today known as Middlewood, and this is how we're going to refer to it kind of throughout this episode, was opened in 1871 as part of a broader regional network of asylums within what was then known as the West Riding of Yorkshire. So patients could be admitted to Middlewood in a range of ways. So there was an option for patients to pay privately to receive care here, but many were admitted as, inverted commas, paupers, and their care was paid for by poor law authorities. All admissions hinged on a signed medical certificate, which confirmed that they were a person suited to be confined, primarily because they were deemed unsound of mind. But after 1890, private patients also required a legal certificate to ensure that they were not wrongly committed to an asylum. But by this point, there's also a much broader concern amongst people about kind of the stigmatising effects of the asylum and a general pessimism that some historians have highlighted, which is kind of encapsulated by what the psychiatrist and the last superintendent of Middlewood said, Frederick Thorpe, an ever-increasing tide of admissions and a distinctly pessimistic outlook on the possibilities for cure.
I think some people would find it really surprising that you would pay privately to be committed into an asylum. Was that very common?
I think to a degree it was common, but the private option was very much for families who wanted to kind of pursue a different option of care for their loved ones. I think on balance, most people in these asylums were paupers.
So it sounds a very formal process, certification, paupers. Tell me more about that.
Yeah, so by the end of the 19th century, there's kind of a growing number of physicians who were concerned that the kind of legal and institutional combination, the certification and the kind of segregation of people, means that certain groups were fearful of being admitted to the asylum. So in Sheffield, you see efforts to provide alternative service provision. So, for example, we see a nervous outpatient clinic established in the Sheffield Royal Hospital, so a local voluntary hospital. This was a clinic that was established by a physician called William Crochley Sampson Clapham in autumn 1893. And this was specifically targeted at, and I'm quoting here, the large number of patients of the class slightly above paupers who declined to present themselves for treatment at an asylum, who were in the early stages of their malady and therefore much more amenable to treatment than the advanced ones.
What a great name, William Crochley Sampson Clapham. Chris, was Sheffield, South Yorkshire ahead of the game nationally in this level of provision at this time?
Certainly 1893 is very early. I think the earliest clinic is in St Thomas's Hospital in London, established in 1892. But really we're getting into sort of definitions of what does it mean to call something a psychiatric clinic? What kind of psychiatric provision or scrutiny is that? I can certainly say that the first sort of specialist department for psychiatric outpatients is not until 1918 in London. So the 1890s is really at the bleeding edge of this kind of provision. And I think one of the reasons for that might be that it's in Sheffield because there's a link between industrial medicine, so people who have certain kind of industrial accidents at work, needing to be assessed both physically and psychologically. There are some changes in the law regarding compensation for workmen in the 1890s, and my hunch is that this is part of why Sheffield might be right there at the bleeding edge, because it is very much involved in heavy industry.
So let's move a little bit further forward. So the early 1900s and the interwar years, does this kind of emphasis in outpatient provision continue?
Yes, in the interwar period it does, but there's an event before the interwar period that actually makes it the interwar period, the First World War, that I think actually is the most important thing to focus on when we're looking at transformational change. Because what happens in the First World War is that there is a huge population of soldiers who succumb to shell shock, which is eventually understood as a psychological or psychic or nervous kind of complaint. And some of the more reactionary members of the British Army want to shoot all these men as malingerers and deserters, but they can't do that because actually that would be terrible for morale and the war effort. And so the solution that they sort of hit upon is we need psychiatrists. We need psychological expertise to help us understand this, to help us get these fighting men back to the front, to heal them if we can. And what that does is it takes psychiatry away from this huge centre of gravity, which is the asylum, and says, well, here they are on the front lines. Here they are helping with the war effort. And that's an enormous amount of prestige for psychiatrists. And the second thing that shell shock does is it really helps to debunk the idea that people who get mentally unwell and end up in asylums are of lower class, from lower stock, and have bad heredity, sort of bad inheritance as a real contributor to mental illness. And the reason for that is that a disproportionate number of officers succumb to shell shock. These are men who have the right families, who have been to the right schools, who are from the upper classes, and they are also getting psychologically unwell. And so that really undercuts the idea that mental illness is only something that happens to people who are seen as not really worth very much. And so that is a real step forward in saying, actually, mental illness can happen to anybody.
So I'm just thinking about some of our prominent figures in Sheffield around this time. Sir Arthur Hall, who was the physician at the Sheffield Royal Hospital and became Professor of Medicine at the University of Sheffield. It's a prestigious chair. We have Steve Renshaw, who is the current occupant of that chair, respiratory physician. But Sir Arthur was a prominent figure in the Sheffield medical community. Do we know, Kate, what he thought about these efforts to move psychiatric provision outside of the asylum?
So I don't think we should overstate this. We know that there was kind of outpatient provision at the Sheffield Royal Hospital since the late 19th century, but this does seem to have expanded in the 1920s, and Arthur Hall is very much an advocate for this expansion. He kind of takes a central role in pushing forward the development of existing provision to facilitate closer collaboration between the Sheffield Royal Hospital and Middlewood via a jointly run mental outpatient department, which was established in 1927. Hall was perhaps a little bit of a workaholic. His students nicknamed him Lord Arthur. He worked at the Sheffield Royal Hospital and sat across various advisory boards. But in the 1920s, he was also appointed as a visiting physician to Middlewood. He was also somebody, though, who was committed to healthcare in Sheffield. You know, he wanted to make the best of the system for the people of Sheffield. And he's been also remembered as somebody who was kind of into empathy as a way of ensuring efficiency within the healthcare system. So within this, he emphasises the value of close cooperation between Middlewood and the Sheffield Royal Hospital. And he argues that it allowed cases to be taken in hand at an early stage before certification was necessary, and therefore, through this, to escape the necessity of certification at all.
So by the time we get to the 1930s, and I think a key piece of legislation there, the Mental Treatment Act, we'd already begun in Sheffield this way of being able to deliver healthcare to people with mental illness without the need for this, quotation mark, stigmatising process of certification.
Yeah, and I think that's fair. You know, Sheffield is very much trying to develop this kind of outpatient provision before the Mental Treatment Act. But we do have to be a little bit careful when we think about the kind of practical impact of those changes. So in Wakefield, a place that was in the West Riding of Yorkshire, historian Alice Brumby has kind of questioned the value of outpatient provision and shown how this actually only often benefited people with what were seen as mild or incipient forms of mental illness like hysteria. The provision within the Sheffield Royal Hospital was also hampered by pressures of time, of resource and of space. So this may be familiar to many of our listeners, perhaps to Helen as well. You know, these pressures that hamper the ability to deliver psychiatric care. And this was something that was highlighted by a physician called Edward Fretson Skinner, who in 1937 was the man in charge of running the mental department at Sheffield. And he commented that it was only possible for 2 physicians to devote 1 half day or 3 hours per week to seeing patients. So he kind of acknowledged that actually any successful treatment of mental illness was very much stultified by the number of patients seeking treatment, which meant that they could only realistically hope to treat half a dozen patients per year.
Gosh, that seems like a really low number. Helen, you're the current Executive Medical Director for Sheffield Health and social care and you're a consultant psychiatrist. Based on your experience, what kind of numbers of patients would you anticipate would require treatment at this time in a city the size of Sheffield?
Well, it's interesting, isn't it, Alan? Half a dozen patients a year isn't going to cut very much, is it? I mean, we still feel that we're underfunded today, but compared to what was available then, of course, we have, very significant numbers of patients being treated across Sheffield or supported across Sheffield. I have to say we still have about 150 beds in Sheffield for people with mental health problems, a majority of whom are still detained under the Mental Health Act. But the majority of the work that we are commissioned to do now happens in the community, and we treat large numbers of patients in the community at any one time. That would be about 17,000 patients are receiving treatment within a year, and there are about 1,000 new episodes of care happening every month. So lots and lots of things going on in the community, but also some provision of beds. And of course, that's delivered by a whole range of different staff, including psychiatrists, psychologists, nurses, and increasingly people with lived experience as well.
So by the time we get to 1948 and the foundations of the NHS, I mean, we were well on the way, I think, locally in moving mental health care out to the asylum and into the community. But does that really help change the dial on stigma associated with mental health? Chris, what was the effect of the formation of the NHS?
So one of the things that people might not know about the negotiations around the formation of the NHS is that until very late in the process, the asylums and the people who still ran these asylums did not want to be part of it. It was that was a very late decision, and in the end it was decided that yes, over the wishes of the people running them, the mental health care provision was going to be included in the comprehensive service. And in the NHS Act in 1946, it says that the Minister for Health will be responsible for the physical and mental health of the people. This is an enormous change. You are bringing together physical and mental health, and this has potentially an enormously destigmatizing effect. Very much plugs into what we, I think, still call parity of esteem between physical and mental health. One of the things that the NHS Act does, it takes a lot of the practicalities of running an asylum out of the hands of the people who used to run them. So stuff like running laundries, doing repairs, like providing staff, all of that is now done under the auspices of the Department for Health. It's not separate. It is completely bundled in with general hospitals and general healthcare. The one thing that remains is a body called the Board of Control, who deal with sort of legal side of freedom and certification, but everything else about the asylum is absorbed into general healthcare. And what then happens is, as the 50s go through to the 1960s, we have a very famous speech by Enoch Powell. It's called the Water Tower speech, and he rails against the old Victorian asylum. He says, there they stand, isolated, majestic, imperious, brooded over by the gigantic water tower and chimney combined. His very grandiloquent speech. And what he's trying to do is to say, right, we need to knock down these asylums. We need to get rid of them in order to provide better care. And that's great. People agree with him. What he doesn't do is provide extra money for that care in the community. So it sounds great and progressive. But what we know about Enoch Powell, well, we know many things about Enoch Powell, but one of the things is that he is not a huge fan of state expenditure, wants to shrink the state. And so you can see part of this move towards the community as a destigmatizing move. You can also see it as a bit of a cost-saving move for a Conservative government.
And on that note, what was happening in Sheffield around that time?
So again, referring to kind of some of the work of Frederick Thorpe, the last superintendent of Middlewood. In Middlewood, this period saw kind of increased efforts to prepare patients for the return to the community. So in 1961, we see an industrial therapy unit established. And then in 1966, we see a domestic training unit. So this is about kind of setting up people to return to the home. So there's a really interesting development in this period within Middlewood, which we still don't know that much about, that's very much preparing people to return to their roles, the kind of set roles within the community. But this period also sees people like Frederick Alec Jenner start to test new psychiatric drugs in Sheffield. So Jenner's a psychiatrist. Well, he becomes a psychiatrist anyway, and he's testing drugs like lithium in the unit for chemical pathology of mental disorders, which is established at the university by the Medical Research Council and runs between 1965 and 1967.
I'd not heard of Jenner before we were preparing for this recording. Tell me a bit more about him.
So Jenner is a really interesting guy, to be honest with you. He has been described by some as the psychiatrist of his generation, but he was appointed as a lecturer in Sheffield by Erwin Stengel, who himself is a very famous psychiatrist trained by Freud and who was the first professor of psychiatry in Sheffield. Jenner, though, was in practice for 50 years, and at one point he was responsible for managing the psychiatric services for the whole of the Trent region. So again, we're talking a lot about different areas here. The kind of geography is changing a lot over this period. But this is a population of 6 million. But Jenner wasn't always interested in psychiatry. He actually started out with an interest in biochemistry of mental disorder. But as he's testing the effects of psychoactive drugs like lithium on people's behaviour, he finds that actually their behaviour seems to be more influenced by what he thinks is their social context. So rather than adjusting the kind of dose of a drug, he kind of moves people between different spaces and sees that that's what's changing their behaviour. And Jenner kind of later reflected that it was this that really brought him towards a social psychiatry view, but also to kind of value the voice of the patient and to be more sceptical of what he described as the medical model of mental health conditions.
So he was a really important player in this shift of care out of the institution and into the community.
Yeah, I think he was. He was a proponent of the idea that you could deliver mental health care outside of a mental hospital. And he also believed that an institutional approach might actually lock a person more centrally into what he described as their misery, rather than helping them to recover from their condition. He kind of thought that sending people to Middlewood isolated them and informed, and I'm quoting here, medically authorised stigmatisation that limited their recovery.
And we've actually got lots of studies from the 1950s onwards that are really focusing on the home environments, the social setting of people who are, for example, recovering from schizophrenia. And they find that people recover much more quickly if they have a stable home life. And one of the things that you were saying, Kate, really sort of sparked this off in me, this sort of recollection that it's not just that the community is good, it's that the asylum could be bad. The asylum and its structure and its uniformity and its control is not just something that you might consider to be unjust, but it's actively harming people from getting better. It's actually stopping them because it's not allowing them to relate to other people in a natural way that is part of their recovery. So the community is one thing, but it's the characteristics of the asylum as such a uniform and regimented place that's stopping people from recovering that is a really core part of this argument.
Helen, as a psychiatrist yourself, how's Jenner viewed today?
Well, I think Jenner, who's still spoken about in psychiatric circles in Sheffield, and there are still consultants who remember him, is seen as someone who was at that tipping point in the way that we understand mental illness at this time, when we were moving away from the idea of biology, drugs, chemicals, into a broader understanding of the etiological causes of mental illness and indeed the social determinants of health that we might talk about nowadays, which underpin all of those: poverty, housing, employment, family connections, social connections, which are so critical and now seen as being so critical in the treatment of people with mental health difficulties today. And it was his transition from being someone who was interested in testing out drugs, which is where he started out with, which is a valuable thing to do, to really understanding and moving in quite a radical direction to taking on board the research that was being undertaken at that point, which Chris has alluded to, thinking about the stresses of life which contribute to mental illness, the environmental, etiological elements that contribute to mental illness, and really enacted that in a big way within Sheffield at that time.
So what kind of changes did Jenner envision?
Jenner believes that actually mental health provision needs to go further. You know, it doesn't need to just move into the general hospital, but that it has to actually move away from institutions kind of as far as possible. Not entirely, but as far as possible. And he's kind of talking about then user-led mental health services. So he is very much inspired by a lot of what is happening in Italy at this time. And he thinks that mental health provision should include art studios, sports grounds, restaurants, and kind of self-governing cooperatives.
I think something which is really powerful about Jenner is the emotion that came into what he was doing and the passion or the values-led approach that he really demonstrated. He was outraged by what he came to see as happening in the asylums, particularly in some of the services that we had for elderly patients at that time, the so-called psychogeriatric services, and also about the way in which we treated people with addictions. And that outrage led to him adopting a very different approach to how to go about treatment of mental illness, but also a very different approach to engaging with people. So he set up magazines, he ran groups, he involved patients, he involved community leaders. He thought about housing, environment, community connections in a very different way to what had previously been undertaken, and became what we would now sometimes describe as a social psychiatrist, someone who was far more interested in social interventions and what could be done and empowerment of people with mental illness than where he'd been before. So he really demonstrates that transition across the spectrum of the way in which mental illness is seen.
One of the things I think is so interesting when thinking about destigmatization is that you have that strand of it that says, let's connect this to people's social setting, let's understand how anybody can become mentally unwell if they're in very stressful environments or they have traumatic things in their past. But this other strand almost seems to be the opposite to that, which is to say, well, actually, mental health and physical health are very similar. Let's emphasize the physical, physiological aspects of mental unwellness. And that's also a destigmatizing move in some ways, but it's completely different to this very socially focused one. And I find the sort of the thread of those two efforts at destigmatization to be really interesting because they don't tend to match up with each other. And I think with Jenner, with this focus away from drugs, which is very physiological and in a way very destigmatizing, he completely goes away from that and goes into the social setting, which is a different way of trying to destigmatize.
I think then it's really important to come back to that idea of what the asylum was actually achieving within society. Often asylums were situated on the edges of towns where mental illness could be packed away in an invisible way so that society and people within it didn't have to address the discomfort that sometimes resulted in. And of course, what Jenner achieved through his move towards the social psychiatry movement, which was at the same time as the deinstitutionalization that went with the closure of the asylums, which he led here in Sheffield, is that discomfort that comes from people with mental illness being much more visible in society, which I think leads to another type of stigmatization, actually, because rather than being the invisible stigmatized, they then become the visible stigmatized. And that's something which I think society is still trying to come to terms with.
One of the things that slightly blows students' minds when teaching them about sort of the origins of the asylum is that people originally thought that the asylums were on the edges of urban areas, not necessarily to hide them away, although I'm sure that was part of it, but it was thought that this was therapeutic. This asylum, this place of safety, was supposed to be detached. It was supposed to allow people to recover. And of course, very, very quickly, this does become exactly what you're talking about. It becomes out of sight, out of mind. And people then have to really reckon with how do we feel about people who are mentally unwell, being in society and being visible in society. What do we do about that?
Yeah, it is a challenge that we face all the time. And even the word care in the community has become so emblematic of a way of helping people, but which is also inherently troubling to people as well. And just to go back to the asylum for the moment, whilst acknowledging all the problems that were associated with it, we also have to recognise that asylum provided care. It provided nurturing environments, or at least it was striving to achieve that, and occupation in a way that we would actually now recognise as something that we value within the management of people with mental health difficulties.
Now, Helen, you mentioned a few moments ago about a magazine that Jenner helped to create. Kate, tell me more about that.
Yeah, so Jenner is actually part of a team of professionals, academics, and people kind of living with mental health conditions who established Asylum. And this was a radical mental health magazine, which was established in the spring of 1986 and is actually still going today. And it's really to provide a platform to voice and discuss all perspectives on mental health. But Jenner's also, making changes within provision too. He kind of, what I understand, to have provided the funds for McMurphy's, which was a self-help drop-in centre that was run by people living with mental health conditions and was just described as a kind of alternative space for people to strengthen their social networks in an attempt to combat the alienation that comes with living with a mental health problem.
Now, I looked online last night and I actually found the website for the Asylum magazine, and it is still going. But it's really powerful. The imagery associated with it and also some of the writing is really quite powerful and moving.
It's an amazing resource, to be honest, particularly for the historian. As I understand it, the kind of back catalogue is now held by Wellcome. And I think there's a lot to be learnt, not only about Asylum magazine, but also how that emerges within Sheffield, right? Like, what are the conditions within Sheffield that drive the emergence of that magazine? And what is it about Sheffield? Why is Sheffield important if we want to understand this kind of massive shift in mental health care and how it's delivered in the late 20th century?
So this massive shift was really taking place at Pace. Was everybody on board? I understand some voluntary organisations were a little sceptical about these changes.
Yeah, I think it's become clear that, care in the community is a controversial thing. For Jenner, he kind of believed that actually for most patients, the move into the community was therapeutic and cost effective, but he also tempered this, right? He noted that there was always going to be some kind of institutional provision needed, and that also for a lot of patients, it was very difficult to be kind of turfed out of a place that had become their home. And in Sheffield, like you say, voluntary organisations were also sometimes sceptical. So when asked in the 1980s about the possible closure of Middlewood, a representative of Sheffield Mind said that it must be remembered that the hospital has become a community itself, and the rights of residents must be remembered.
Yes, that work that he did with service user groups was controversial and, as you say, liked by some and not by others. I was chatting recently to somebody who still works for us as a psychiatrist in Sheffield, but is also an honorary professor at the University of Sheffield, Tim Kendall, who remembers Jenner well and was, sees him as being a mentor, and remembers the struggle that occurred both within the psychiatric community about how that was seen, but also within the user groups as well. He was obviously quite a radical, wasn't he? And, Tim has stories about going to his house late at night and putting together this magazine and, heated arguments about what should be going on there and what shouldn't. But I think although the word wouldn't have been used at the time, what we're really seeing there is the beginnings of something we would now recognise as co-production, which is professionals and people with lived experience of mental illness working together and working through the complexities about discussing this in a public forum.
As a historian of modern British medicine and psychiatry, I think there's a really good opportunity here to maybe trace a history of co-production, maybe to look at this in Sheffield and to understand how this relates to what's happening within Sheffield in this period.
One of the things that struck me that you said, Kate, when you were asked to speak about the Asylum magazine, you said, it's a great resource. And I think one of the things that's really hamstrung historians when trying to look at the voice of the patient, if you like, is the lack of reliable documentation, the lack of material traces of what people who had mental illnesses said and thought. Because in the 19th century, there wasn't much provision or ability for people like that to write and to leave records. And so one of the things about this magazine, it's incredible in so many ways, but for historians, it really provides a basis from which to make relatively robust conclusions.
Helen, do you think we've helped reduce the stigma, or have we still got some way to go?
Well, Allan, I think we've got a long way to go. I don't think anybody would say that we have dealt with the issue of stigma of mental illness. In particular, I think, although it's become much easier for individuals to talk about mental illness with friends and families and in communities, it's still incredibly difficult to talk about some elements of mental illness. So people may be comfortable talking about their depression or their anxiety or their OCD or their, whatever. But to talk about schizophrenia, to talk about personality disorder, to live with learning disability, dementia, these are still very stigmatised conditions within society today.
We wanted to hear from the managing director of a local mental health charity, Sheffield Flourish, Josie Soutar. She wasn't able to make the recording today, but in a separate interview, we asked her about the current focus on care in the community. And here's what she said.
Communities are massively important for supporting mental health, whether that's on an individual level or societal or community-based. That's where it really needs to happen. You know, one of our big philosophies at Sheffield Flourish is we're trying to create a mental health friendly city. We're trying to create mental health friendly spaces. And I think sometimes when we label things as mental health in the community, we're already causing a stigma. We're already going, oh, that thing's for people who are mental, rather than kind of saying, no, that space is for people to support their mental health or their well-being, or to feel like they belong or in an environment that is friendly to them, regardless of where they're coming and what their background is. You know, we're called Flourish for a very particular reason. We like to think about how we can move people beyond their diagnosis and beyond the idea that they are their mental health condition and that's all they've got going for them. Our art group is not an art group for mental health. It's a mental health friendly space where artists like to go and do art. It's a small difference, but a big one. So I think when we're talking about mental health and stigma, a massive thing is the language we use, is how we portray things when we're marketing them or promoting them, what we say they are and to who. So if we are tagging things which look like a hospital in the image, or doesn't show people that are particularly look like me, then I'm going to think, oh no, that's for the really crazy people. I'm just struggling a bit with, you know, social anxiety, so I'll just try and muddle on through. So for me, barriers are a lot to do with how we present mental health in the community, how we present care, and, you know, in inverted commas, what do we mean by care in the community? And I think we're making some ways in that. And I think as a society, you know, we're recognising that talking and supporting each other and realising that mental health isn't something that happens to someone else. We all have mental health, that age-old kind of classic. And then therefore, hopefully that starts reducing some of those barriers. I also think there's massive barriers for particular communities. You know, we've been doing a lot of work with partner organisations, but also with Sheffield Health and Social Care, looking at race in particular. A number of years ago, my board of trustees, I think they were quite brave at the time, this was before George Floyd or Black Lives Matter movement, we were looking at who is residing on the mental health wards and who's accessing our groups, and there was a massive disproportion. Basically all of our groups attendees were white, and on the mental health wards it was about 75% non-white. So we weren't doing our job somewhere. And I think it's not just about the barrier of mental health, it's also the barrier of where you see yourself, what you see is open to you, you know, not constantly saying, well, people are hard to reach. You know, I'm hoping we're moving away from that these days, because actually it's maybe as an organisation we're hard to reach. We shouldn't expect to build a service and people will come to it. The idea of co-production and really hearing from people. I think we've learned a lot in Flourish from the digital world in particular, like websites, they go through so much kind of user testing, because essentially if someone uses a website and it's rubbish, people aren't going to go back. Whereas we don't do that with real life services. We kind of build this thing and say, oh, and we're only going to be open at 4:27 on a Tuesday until like 2 minutes past 6, and if you've missed that window, tough. And it's bonkers really. So until we start really listening to our communities about what's going to help them, how can we help people access things, how can we take support and care to them, then we're just going to be in this same cycle with huge waiting lists and people getting iller.
Helen, is Sheffield still at the forefront of transformations in mental health care and addressing the stigma?
Yes, Allan, I think we are. We have a very well-developed and well-performing talking therapy service, which delivers talking therapies to over 6,000 patients a year. That was a development that occurred in the 1990s, but has been developed interestingly, across the range of different common mental health problems such as anxiety and depression, which, as we were referring to earlier on, often interfaces with people with physical illness and disability as well. We've also been involved in a number of transformation projects along with primary care and the voluntary sector, really taking the power of the voluntary sector in Sheffield and commissioning them, providing them with money to deliver services that are meaningful and appropriate for the wider community in Sheffield, thinking particularly about the needs of some of our more disadvantaged residents. The work that's been done in primary care is really exciting, I think, because it's really taking people back to the communities that they live with, thinking about the strengths in their communities, the people who understand what's needed in those particular areas of Sheffield, which means that you might get a different flavour of mental health treatment if you live in the north of Sheffield from somewhere in the southwest of Sheffield. And I think that's appropriate. That's what we sometimes refer to as population health, thinking about what the actual needs of communities are.
We also asked Josie Soutar the same question.
We really need to stop thinking about mental health as the responsibility of the NHS. So there is a thing about mental health support that goes far beyond groups and counselling and psychiatry and all of that kind of area. What we need to think about is, what does Sheffield feel like as an environment? Now, there are certain things that cost of living crisis, we know the links with poverty and mental health are pretty extreme. If we could give people better places to live. When I think about what Sheffield looks like now, all of these green spaces, Flourish is based on the Wicker, and I cycle to work, and there's a wonderful cycle path that goes past all of these wildflowers that have been planted. Just things like that lift you and make you care about your environment and think slightly different about your day. Now, I'm not saying plant some flowers and that's just going to fix mental health crisis in this country. But I think what we need to do is start planning everything with mental health in mind and well-being in mind. The links to the environment are significant. So I think all the changes that are going on in Sheffield at the minute to make it feel like a city centre that isn't just based on trying to encourage people to go into shops, but encourage in people to be there and enjoying the space. All of these things, I think, starts reducing barriers and starts helping people to feel slightly better about their lives and the environment that they're living in.
Josie Soutar there, Managing Director of local mental health charity Sheffield Flourish. As we've heard, Sheffield has a very interesting long history when it comes to mental health, stigma and healthcare. We mainly looked at the changes supported by people like Hall, Jenner, as well as service users to address stigma, but I sense we still have a lot to learn about how these changes were felt and experienced by people living with mental health conditions themselves. We're coming to the end of our time together, and I just wanted to gather some final thoughts. If you had one thing that you could change, let's go around the table. Helen.
I think I'd have to choose what we might call parity of esteem. The health burden from mental health problems in terms of how it impacts on people, on communities, particularly on more disadvantaged groups, and also on our productivity as a country is massive. And we know that if we invest more in mental health services, we can help people live more productive, more contented, and in the end of the day, happier lives. That's good for all of us.
Chris?
Yes, I have a vaguely boring answer, which is money. It's resource. I think so often when people in the past have talked about care in the community and have talked about moving away from institutional provision, this has been used as an excuse to not fund some things that are quite expensive, however flawed they may be, and to save money. And I think one of the things we have to recognise, as Helen said, the burden of mental illnesses is so enormous. I want to get away slightly from that economistic logic that says, actually, this is worth more in the long run, and say, it's just worth it. It is worth it because people are really suffering, and we have to really want, as a society, to commit resource to some of the most vulnerable and most disadvantaged people. When it's time to talk, it's not always time to spend, and I really want to get that across.
Kate?
Yeah, I mean, I think for me, it's less about what I would change, but about how I want to change it. And I would say this, but I think we can really learn a lot by looking at Sheffield and telling the Sheffield story, not least because of, all the many ways that stigma and discrimination continues to kind of affect people living with mental health conditions today, but also because of how looking at Sheffield helps us to understand what changes are made, but how they translate in practice, who they are kind of benefiting and who doesn't get to benefit. And I do think, if we think about how we might change mental health care, looking at history, and I'm not going to say learning lessons from the past, but history is a really important tool to help us to understand how we've got to where we are, and also to think about how things could be different. And I think for me, there's a quote from a historian called Barbara Taylor, and this very much resonates with me. And she said, people with or without mental health conditions depend on other people to lead a decent life. We do not really need history to tell us this, but history can show what happens when we forget it.
What a poignant point to end on. Thank you. You've been listening to the Overend-Knight podcast. And my thanks go to Kate McAllister and Chris Millard from the University of Sheffield, Helen Crimlisk, consultant psychiatrist at Sheffield Health and Social Care NHS Foundation Trust, and Josie Soutar, managing director for Sheffield Flourish. The sound recordist today was Dan Smith, and this podcast was produced by Andy Tattersall and Sheila Francis. I'm Allan Pacey, and until the next time, goodbye.
To complement the historical approach, our colleague Dr. Chris Blackmore from the School of Medicine and Population Health presents in his podcast an in-depth look at the changing nature of the language of mental health informed by the Middlewood Hospital in Sheffield. With his guests Amanda Crawley-Jackson, Ian McMillan, Patrick Murphy and Brendan Stone and collaborators Sheffield Flourish, Chris examines the language of mental health and how this has changed and continues to change over time. The podcast arose as part of the Mind Your Language project, a creative imagining of the dialogue between past and present, in a form of an exhibition, a public talk and a book created by Patrick Murphy and Ian McMillan. This was a 2024 Festival of the Mind project from the University of Sheffield. You can find the link to that recording in the show notes to this podcast.